Well, good morning, everybody. My name is Chapman, and today is September 6, 2024, and I'm welcoming you to this edition of our virtual Spine Journal Club. I want to thank Spine Art for the generous academic support, and for those who are expecting our colleagues from the Rothman Institute, I apologize. Dr. Kepler and team were prepared, but then they had a very urgent scheduling conflict. So they send apologies, and they're going to be doing the next sessions as planned. But there was a unavoidable scheduling snafu. I do want to thank them for their generous participation, and you, our audience, for your interest. And I want to credit our fellows. There are 5 of them presenting today with coming up with a topic that you've heard of before. Just 2 weeks ago, we had Dr. Placide and colleagues from Richmond, Virginia, talk about spinal infections. And as reflected back then, this is a growing and substantial problem, not an exotic byproduct. And in our clinical practice, easily once a week, twice a week, we have de novo, as we call them, so new spine infections that perturb us and cause us problems. So today, 5 of our fellows have put together articles that don't just go through the basics, but hopefully entice you and give you food for thought with considerations that you may not have had on the front of your mind. And so we thought we'd kind of go with some topics that we've not always kind of thought of as primary things or maybe took for granted, and we're revisiting them. Again, all 5 topics were selected by our fellows, and I want to thank them for their input, their rapid pivoting towards getting it done, and their intellectual work in kind of discussing these articles. We'll lead off with Dr. Mark Kramer. He is one of our fellows, and he is representing us at the AO Spine North America course in Florida. And Dr. Kramer, good morning to Florida, where it's 9 o'clock in the morning. How was the AO Spine meeting?
Oh, it's been great. Yeah, it's definitely hot down here, hot and humid.
Yeah. What's the topic of the meeting?
So it's controversies in the field. Cervical yesterday and lumbar today. So
your topic is very pointed to that, right? I mean, this is exactly up your alley there. Tell us about your presentation, and thanks for dialing in from Florida, from the AO Spine North America course that you're presenting us at, and tell us about your topic and what you found.
Sounds good. I'll go ahead and share my screen here. All right. Great. So first of all, no disclosures from myself. So the article I chose, let me just move some of the panels here so I can see a bit better. So it's an article that was published back in 2023 in BMC Musculoskeletal Disorders, a group out of Zurich, Switzerland. The title of the article is Pseudoarthrosis After Anterior Cervical Discectomy and Fusion, Rate of Occult Infections and Outcome of Anterior Revision Surgery. Just to give you some brief background, pseudoarthrosis, obviously a known complication of any spinal fusion. Rates of pseudoarthrosis after ACDF are generally fairly low. Rates most reported less than 5%. Multiple patient risk factors have been identified. Of course, age, diabetes, tobacco use, and then of course there are many surgical factors that we consider on our side as well. Multi-level fusions have a higher rate of pseudoarthrosis. Your choice of autograft versus allograft and or cage material, if you so choose. The picture on the top right is a picture from the article showing a classic case of pseudoarthrosis. This is a CT coronal and sagittal, which shows that there's no bridging bone in this previous 5 to 7 ACDF. When patients present with recurrent symptoms and evidence of pseudoarthrosis, oftentimes we elect to take them back for revision fusion. And revision fusion can be performed through a repeat anterior approach or posteriorly. The question that this article raised, so among patients undergoing anterior revision for pseudoarthrosis through a repeat anterior approach, first of all, what is the clinical outcome at 1 year in regard to NDI, visual analog scale for neck arm pain, and the NAS patient satisfaction score? And then also, what does the microbiologic analysis of the explanted cage or plate demonstrate? So this is just a brief review of the methods that for this paper. It was a very small retrospective review. They looked at a case series from 2017 through 2021 and identified approximately 100 revisions. Most of those were done posteriorly, important to note. And their inclusion criteria, importantly, were pseudoarthrosis based on a CT, obviously an anterior approach for the revision, and then 1 year follow-up data with the satisfaction and different scores noted below. So in total, only 10 patients were actually included in the final analysis. In regard to the patient demographics, again, a very small cohort, but it is important to note here that there were a high number of smokers in this small patient cohort. And to the results, just briefly to lay the land here, among the 10 cases, there were a couple different types of operations done at the index operation. 4 of them were single-level ACDFs. 4 of them were 2-level, and 2 of the cases were 3-level ACDFs. It was not reported exactly what the timing was for the revision surgery. And by the author's own report, they elected anterior approach due to clinical factors that were determined in the clinical setting. And the thing that was surprising in this article is that they identified occult infection in 4 of these 10 patients. The bacteria identified was Cultibacterium acnes, which is previously P. acnes. And among those patients that had Cultibacterium identified, they were all treated with antibiotics. And 8 of the 10 patients ended up undergoing having evidence of fusion at the 1 year mark based on a repeat CT. And I guess the last thing to note here is that the clinical outcome data are reported on the right. And interestingly, the NDI, visual analog scale for neck, arm pain, and the NAS satisfaction scores were actually not significantly improved at the 1 year mark compared to preoperatively. So I guess to the discussion, just based on this very small patient cohort, it's very difficult to assess clinical outcome in regard to revision surgery in the case of pseudoarthrosis after ACDF. So and that's not relevant to our discussion, I guess, necessarily today. But what was very interesting in this case, small case series retrospective, was that C. acnes was identified in a high number of these patients. And it's obviously it's a slow-growing bacterium. It can take quite a long incubation to identify it. They oftentimes form biofilms. And of course, there's always, in any of these cases, potential risk for contamination, which can confound the results. So the question is raised, is occult infection more common than originally thought in cases of pseudoarthrosis? And I just briefly bring up another series that was published also by a group out of the same hospital in Zurich, which looked at thoracolumbar pseudoarthrosis revision surgeries, where they also identified about 10% of cases with where specimens were removed, demonstrating occult infection with either a coagulase negative staph or C. acnes. So just briefly, conclusions. Obviously, there are many limitations for this very small study, very small sample size. Important note, most of these revisions probably in most hands are done posteriorly, so you would never even go back in and collect this material for sample. And then, there's also questions raised about standardization of the microbiological analysis. How do you confirm that these are indeed true infections, or is this a contamination? But for me, this raised a couple important considerations. First of all, for any kind of pseudoarthrosis case, should we be collecting cultures routinely? I think from based on what I'm reading from these papers, I would say yes, we probably should. But we need to be careful about what that data leads to. Should we be, does that mean that all these patients should get a prolonged antibiotic course? And then this also highlights for me also the importance that this bacterium is identified in the skin, sebaceous glands. So it's certainly important to think about disposing that skin blade after it's used to make that initial skin incision, because that could potentially also be a source for contamination.
Great stuff. Is my microphone? Okay, great stuff. Thank you very much, Mark. We have the great honor and pleasure to have Dr. Ricky Placide with us this morning from Richmond, Virginia. And just again, I said in the intro, he and his partner, Dr. Judy Resnicek from the infectious disease group at VCU, gave an outstanding STED talk the other day. Thank you for joining us impromptu, Dr. Placide, and thank you for that phenomenal instructional course like STED talk. Just 2 weeks ago, we heard that poor Dr. Resnicek is not well, and we wish her all the best for a rapid recovery. So 2 questions for you, Dr. Placide, if we may impose on you. So these infections in symptomatic non-unions in the cervical spine, the simple, and I'm a simple person, as you know, question to me is, were these inoculations that happened at the time of surgery, or did this opportunistic infection happen due to instability? What was first, chicken, egg kind of question?
Yeah, well, thank you for the presentation and the introduction. Thank you, Mark. So over the last several years, in many of our pseudoarthrosis cases, we routinely send cultures. Probably the last 4 or 5 years. Not as much on cervical, because as you know, it's more rare, but fractured thoracolumbar hardware, where there's clearly evidence of a pseudoarthrosis, we certainly send cultures on all of those. 15 years ago, I didn't do that. Was not aware of the problem. So I think in these cases, it is likely that it's a skin contamination, because some of the points that Dr. Kramer brought up, I think, are not honored and thought about during a typical procedure. So I do agree with the potential skin contamination, knife blade, changing it out, that type of thing. But on the other side, and I'll speak a little bit for Dr. Resnicek because she's not here, you typically like to send multiple cultures from different sites. So for example, we are not a fan of just scraping out the disc space, for example, and sending one culture. Because if that's positive, you have no idea if that's a contamination, because this is a likely contaminant as well in the microbiology lab. Like if you've ever gone to the lab and see how they do this. If you have 3 separate specimens from different areas and 2 of the 3 are positive, then it's likely an infection. If 1 of the 3 or 1 of the 4 are positive, probably not infection, likely contaminant.
Great answer. And then one more follow-up question, then we need to move on with Dr. Gold. We have a busy agenda this morning. This has happened to me before. I've done a revision surgery. I've sent off dutifully 2 to 3 specimens. I try to do 3, but sometimes I fall short of that. And everything looks okay. There's no clear infection present. Slimy tissue is found, clean washout, nice debridement, re-instrumentation is done. And a week later, I get the positive turning of, let's say, Cutibacterium notice in my email. What do I do then? The patient has been going home, is at home now, is walking around. Do I start an IV on them? What do I do? I have a late conversion notification of one of those opportunistic bacteria.
Right, so that's a very good point. Typically, we ask them to culture it for 2 weeks, which is not a typical culture. If we're concerned about that, it's a 2-week growth because it can show up after the week. But in your scenario, what I would do is I consult with infectious disease, and we look at comorbidities that I put a lot of extra hardware in to determine whether there is a short course of IV antibiotics. It's not typically the 6 weeks, might be 2 weeks. But sometimes the infectious disease folks just settle on an oral antibiotic.
So that's a great point. Must move on. It's so good to have you here, Dr. Placid. And again, all of our viewers, please go into our library and look at him and Dr. Reznicek's fantastic STED talk from just 2 weeks ago. Dr. Colin Gold, a neurosurgical colleague from the University of Iowa, is going to present an article on diagnostic considerations as we approach spondylodiscitis patients. Colin.
Morning. Thanks everyone for coming. So the title of this article is Total Spine Magnetic Resonance Imaging for Detection of Multifocal Infection in Pyogenic Spondylodiscitis, a retrospective observational study. This was published by a German group in 2021. So for some background on the topic, they define pyogenic spondylodiscitis, SPD, as the topic of the article. Here's the anatomic distribution. Most common historically in the lumbar spine, with 58% of infections there, T-spine 30%, and C-spine 11%. It's well established that MRI is the diagnostic gold standard with 96% specificity and 92% sensitivity for diagnosis. However, it is unclear from prior research how often these infections are multifocal. So for the methods of the study, it is retrospective. The patient population was interesting. It was actually only surgically treated patients with spondylodiscitis, and then they had to have had a previous full spine MRI with and without contrast to be included. And then diagnosis was confirmed in all of these cases, either with surgical biopsy or CT-guided biopsy. And then all patients are also treated with 2 to 6 weeks of antibiotics after surgery. MRIs were graded with this POLA classification, which is 3 separate grades, A being the least severe and C being the most severe. A was cases with neurologic deficit, without neurodeficit or biomechanical instability. B was intermediate with significant bone destruction, or biomechanical instability without deficit, and then C had a neurologic deficit or presence of epidural abscess. So their primary outcome here was to detect the presence or absence of non-contiguous multifocal pyogenic spondylodiscitis, and then their secondary outcomes were to investigate epidemiologic factors that may help in prediction of who would have this condition. So here's some of the data that was collected, normal things like demographics, length of stay, readmission, comorbidities, neurologic severity, and one I thought that was important was pain, localized pain at the site of the infection. So here are their results. This table on the left, really the only significant difference here, actually, no, sorry, I'm looking at the one on the right. COPD was the only kind of separate factor that had any kind of predictive value, but mostly there was no difference in comorbidities between the two groups of unifocal and multifocal, and then also no difference in gender, age, etc. I think probably the most important part of this chart is to see that 12.7%, almost 13% of patients had multifocal infection. And then the breakdown of where pain was also very interesting. They found that patients were most likely to experience pain in the lumbar region. So 44 yes to 4 no's in unifocal, but then that number drops down to 4 to 4 in multifocal. So I don't know what the biological rationale of that is, other than maybe distracting pain. So lumbar pain is the most likely to be experienced, and then thoracic even less so, especially when it's multifocal. 2 did feel pain and 5 did not, and cervical was similar in multifocal. 3 to 3 felt pain versus did not. So I think that's pretty good evidence that there's pretty poor localizing ability just on clinical rationale. And then this is another table that they had showing the breakdown of the POLA classification. So on the left is for unifocal and on the right is multifocal. Basically, this is just showing that type A was the most common, meaning no neurologic deficit and no mechanical instability. And then the conclusions were there were no difference in clinical presentation, comorbidities, and symptoms between unifocal and multifocal disease. Patients with lumbar discitis were most likely to have localized pain. way more so than cervical and thoracic, but still not even close to 100% felt localized pain, especially in multifocal disease. And then there was no difference in age, Charleston Comorbidity Index between the two groups. So ultimately, they concluded that full spine MRI is a useful tool to exclude non-contiguous SPD.
Colin, great topic and very nice, succinct presentation. You come from one of our major programs in the country, University of Iowa. I think those authors used gadolinium contrast. Did I understand that right?
That's right.
What are your thoughts on that? Is this additional biologic burden and scanning time relevant? Do we really need this?
Yeah, so we would always get MRI full spine, if possible, with and without contrast on every patient with a discitis for this reason. I think this was an interesting paper to read to kind of back up that evidence, because I feel like in the past I was just kind of doing it based on anecdotal evidence. But it's always a discussion with the radiologist to say if the contrast is necessary, because it helps. I think in my opinion, especially with a subtle discitis, it can help find it where it's not quite clear if it's advanced degenerative disease or infection. But the big obvious ones, they're going to be operative targets like cord compression or severe kyphosis. Those are going to be obvious enough with or without contrast.
Great point. Dr. Emil Abdul-Jabbar, my partner is here, and he just presented a case this last Wednesday at our STED talk of a multifocal discitis, I think 4 different levels. Tell us a little bit about your thoughts in terms of pain representation, pain being one of the cardinal clinical elements of spondylodiscitis. How does this reflect in your choice, and what was your experience with that patient? I mean, you had 4 levels disease, I think, in this patient.
Yeah, I think it's a great point. I think that's one of the hallmarks of this paper is that the patients will show up because of pain. But there are plenty of patients out there, if you scan them, that do not have pain, especially in the cervical and thoracic spine. I think this patient was a little bit tricky because likely some of those other non-contiguous levels were probably older. And when you get that MRI, it's very hard to know what's an active infection versus not. And I think some of the contrasted studies can help with that. But it just shows the importance of really getting the entire spine. For him, he had 3 levels that we treated non-surgically, only 1 that we treated operatively. And again, that's something that you do want to know about and observe. I don't think all of these are surgical, but you definitely don't want to miss something like that, especially in the cervical spine, that can cause a significant trajectory towards neurologic decline. So again, just reinforcing the importance of really making sure that you have these patients monitored as closely as possible, although follow-up can be a big challenge as well.
Great point. Dr. Placida, if I may impose on you, so I want to thank Dr. Gold for his nice presentation. Is it enough in these patients to do screening MRIs where we do sagittal screens to kind of minimize time? Maybe you can comment on the need for gadolinium contrast as well.
Yes, I actually agree. I've had the similar thought. Typically, we do a standard MRI. We don't do a screening, but that's been discussed in other pathologies as well, like traumas and tumors. So I don't typically get gadolinium. I typically do a non-contrasted MRI. We have not gone to a quicker protocol because I agree with you, less time in the MRI, maybe a faster evaluation of the entire cord. But if somebody has a neurologic deficit, they have a thoracic osteodiskitis and they're progressive paraparesis, I probably am not going to spend the time getting a cervical and lumbar at that point. We'll take care of the problem with an operation and then still follow up with the scans. But no, we have not done a screening yet, but I think it's worth consideration for sure.
Let's stay in the diagnostic. Thank you for those comments, both of you. Dr. Cameron Hogshead is here from the fantastic state of Texas, and he has also chosen a diagnostic topic. Something that's much overlooked in our Western societies is non-pyogenic osteodiskitis. And we do have them with some regularity here, about once or twice a year, I think, right? Amir, you've had a patient with TB not too long ago, Pott's disease. But this is an interesting topic that we don't always look upon. And Dr. Hogshead's topic is, can we differentiate that preoperatively on scanning?
Yeah, thank you. Good morning, everybody. The paper is titled A Clinical Prediction Model to Differentiate tuberculosis, spondylodiscitis from pyogenic spontaneous spondylodiscitis. This was a paper published in August of 2023 out of Bangkok, Thailand at a university hospital as a retrospective study. The motivation for this is pretty obvious. There's a high global incidence of spontaneous infectious spondylodiscitis, up to 24 million cases per year, has a mortality rate of known up to about 20%. And these are both very common causes, pyogenic both and tuberculosis, obviously more endemic in Southeast Asia, but has been shown to increase in incidence as we increase our testing and knowledge of this disease into more developed countries. The microbiodiagnosis of TB versus pyogenic spondylodiscitis is somewhat difficult to differentiate to this point, and there's currently no scoring system for diagnosis of TS, which was a motivating factor for this paper. Their aim was to identify predictive factors for differentiating these two using clinical characteristics and patient risk factors, radiologic findings that we do know about up to this point, as well as biomarkers and laboratory findings, and to create a predictive scoring system using all these factors to stratify the probability of TS. Design and patient characteristics. So defining a pyogenic spondylodiscitis diagnosis, the causative organism was isolated from spinal tissue at a suspected site of infection, or signs and symptoms with positive blood cultures, and predictive radiologic findings were used to make that official diagnosis. For tuberculosis spondylodiscitis diagnosis, they used histopathologic findings of TB or PCR, confirmative studies, or spinal tissue culture that was positive for TB. Note their inclusion criteria. They excluded patients that had infections from prior surgeries or interventions, or patients that had both simultaneous TS and PS infections. Incomplete data was also excluded, such as missing lab or radiographic data that they were not looking at or studying were also excluded. And any patient that did not have a definitive diagnosis per above was excluded. So this is just a data collection flow chart of the inclusion and exclusion criteria. The TS group was 73 patients, and the PS group was 68 patients. Among the 68 patients with PS, causative organisms isolated by the spinal tissue cultures were 75% of the cases, and blood cultures confirmed in about 50% of the cases. Causative organisms were mainly Streptococcus, Staph aureus, and gram-negative bacteria. The same organism was identified in both blood and tissue cultures in about 26% of the cases. Among the 73 patients with the TS group, TB was isolated from spinal tissue cultures in about 67% of the cases, and 20% were confirmed by positive PCR, and 11% were diagnosed by positive findings for granular formation. So the results here I've highlighted in yellow the statistically significant proportions correlating with TS versus PS. And so they found that age for TS was significantly younger, median age of 55 versus in PS older, 62. They found that a history of bacteremia indicated by sepsis, fever, chills were significantly higher in the pyogenic spondylitis group versus the TS group, which essentially had 0 patients. And then active tuberculosis, other than the spine, as we expected, was predominantly found in the TS patients. And comorbidities and diabetes actually had a significantly higher proportion of patients corresponding with the PS group than the tuberculosis group. So looking at clinical characteristics and laboratory findings, they found that the time elapsed diagnosis median was significantly much higher in the TS group at about a median of 90 days compared to PS at 21 days. A very large range there that you could see, ranging from 5 to up to 1,000 days, median time to elapse the diagnosis there. They found that fever greater than 38 degrees Celsius was significantly higher in the pyogenic group as expected, just based on those previous kind of characteristics of history of bacteremia, sepsis, fever, and chills. And then laboratory findings that they found significant were listed there in yellow with all white blood cell count, neutrophil count, ESR, and CRP being significantly lower in the tuberculosis spondylodiscitis group and higher in the pyogenic group as expected. So results from their radiologic findings, also highlighted in yellow there, you can see that the level of vertebral involvement and thoracic was significantly higher in the TS group, and for lumbar, significantly higher in the PS group. There was no significant difference between identifying the organism in cervical spine. As far as number of vertebrae involved, greater than three or greater was more significantly corresponded to the TB group, as well as a paraspinal abscess that was post-contrast, well-defined, as well in the tuberculosis group. And then they also evaluated the wall thickness, and it was found to be thin, which we can show. They have a nice illustration on an MRI in the next slide. That was corresponded more to the TS group. And then the classic pathognomonic anterior subligamentous abscess spread that is kind of already well-defined in the literature was also corresponded with the TS group. You can see that epidural abscess, presence of disc height loss, skipping lesions, all those others was not significantly difference between TS and PS group. Just quick looking over these MRIs here, you can see kind of on the A at the L2, L3 disc space of that sagittal T1 weighted MRI, you can see anterior subligamentous spreading at the disc space. And then in D there, you can see the axial T1 weighted gadolinium enhanced MRI scan demonstrating a well-defined paraspinal abscess that lights up post-contrast, which are all highly suspicious for a tuberculosis patient. Results that they combined, so all 16 of those highlighted in yellow predictive factors, they underwent a multivariate logistic regression analysis to see which ones had the highest predictability corresponding with TS, and they found that the white blood cell count, ESR, neutrophil fraction, and paraspinal abscesses all had the highest odds ratio for corresponding to tuberculosis. And they combined this into a scoring system, as you can see on the bottom right in table 6, that basically corresponds to the prevalence of TB based on their low probability, moderate probability, and high probability scoring system there. So low probability, a score gets you about an 8.3% prevalence of TB. Moderate is about a 30% prevalence. And then if you end up in a high score, it's about a 80% and higher prevalence of TB using that scoring system. So if you see there, you have a white blood cell count with a low inoculant, low virulent organism that's less than 9,700, that gets you a 13. And then if you have the presence of a paraspinal abscess, that's a 10. So you're at a 23 and already very high probability just with those two factors there. So discussion, in addition to the scoring system and all the predictive risk factors that we talked about, do recommend still integration of all these things to obtain prompt and early diagnosis and treatment for these ailments. Scoring scheme did show good predictability, area under curve of greater than 0.9. This patient cohort was overall much higher median delay to diagnosis, which may account for CRP and ESR being significantly different factors, and CRP not making it into the predictability chart. This was conducted in an endemic area, so generalizability is a little bit questionable. It was at a single center retrospective analysis as well. They did exclude patients that had both PS and TS, and this could be difficult to distinguish from other low virulent organisms such as brucellosis or other fungi infections, just because, again, TB is a very low virulent organism, and this is kind of what this scoring system relies on in differentiating pyogenic spondylodiscitis.
Great stuff, Cameron. Thank you. So here's a question to you, Dr. Placide. I would usually ask your partner in the infectious disease division at VCU to comment on this. Do you treat POTS disease patients, TB of the spine?
So we see it very rarely, less frequently than you. In fact, it's more common that I would have a different mycobacterium, spinal osteomyelitis, like Mycobacterium avium, But I do know that Dr. Resnicek, from a non-spine standpoint, does see tuberculosis patients.
So for me, this is still the great imitator, because this paper was really helpful and thoughtful. But I still struggle with a lot of those details because, for instance, we've had several of our last patients actually had concomitant disease. So right there's a confusing element there that I can't resolve. Our ID doctors want us to do routine chest CTs nowadays to look at whether it's miliary TB or productive. That's the first big caveat. The second biggest question, and I'll ask Cameron maybe first, what is the consequence for us to predict it outside of isolating patients? And even then, we would get a chest CT and get sputum cultures to see whether they're productive or not. So what's the therapeutic consequence by kind of diagnosing this?
Yeah, what I think you're asking is kind of what benefits us to getting a quicker diagnosis versus assuming pyogenic versus spondylodiscitis. It's a good question, and the value of that, other than early isolation versus not isolation, and identifying the factor is kind of a benefit. We usually hold antibiotics for these patients too, in most cases, until blood cultures are obtained and biopsy tissue is confirmed anyways. So is there much early benefit there? And between the lag time of getting that information, hard to say. With this information here, you could potentially have more of you still do the workup regardless for both TB and pyogenic spondylodiscitis. And so
I gain benefit of these checklists by kind of going through my mental approach of completeness of assessment. This looks to me like something that ChatGPT could incorporate maybe, so we can have a spinal TB ChatGPT subsection. Dr. Placide, what are your thoughts? Should we just be open-minded on should we treat everybody with a suspicion of possible tuberculosis? How does this paper impact your potential practice? I know it's a low incidence for you. For us, it's not trivial. It's about 1 to 2% of our patients.
Okay. So no, I enjoyed the article. I had not read this article before, so it opened my eyes a bit. So typically I would just go based on history and imaging characteristics to determine if I would send an intraoperative culture for mycobacterium or not. With this added information and lab work, I think I might have to rethink that, in teaching the residents, fellows, and my own education. I think it will change the way I look at a spinal infection patient.
I think the main gist that I get from the lab aspect is that spondylodiscitis patients from non-pyogenic sources are not as sick as pyogenic patients. The pyogenic patients seem to be just overall sicker, meaning more septic-like in their picture. Is that fair?
Absolutely. Higher inflammatory state, higher inflammatory markers, fever, chills.
And ESR is still present. I love it. I still get both. All right, must move on. Next to last speaker, Dr. Nick Manasali. He's coming to us from the Rothman Institute, so you're holding up the flag of the Rothman Institute. Good for you, and we, again, love our collaboration with our Rothman colleagues, and I know Dr. Kepler felt very bad when he called us a couple of days ago. This is, again, an important paper in terms of the classic aspect of how do we decide to treat patients surgically or non-surgically in pyogenic spondylodiscitis. And this is an author group that we, again, don't usually look at. So, Nick, thanks for selecting this article, and tell us what you found.
Perfect. So, this article was out of the Royal College of London, published in 2023 in Scientific Reports. I don't have any disclosures related to the talk. So as an introduction and background, and we've kind of covered a lot of this, but spondylodiscitis has a high incidence and mortality rate can be up to 20%. Chronic infection or subtherapeutic treatment can lead to persistent spinal deformity, neurologic deficits, and permanent reduction in quality of life. And currently, conservative treatment is the most commonly used option, which generally consists of long-term antibiotics. The purpose of this paper was to define the role of early surgery in spondylodiscitis in comparison to conservative management. So this review was conducted utilizing PRISMA guidelines. The literature search carried out in April 2022. Inclusion criteria was any study that compared outcomes of patients receiving conservative treatment versus early surgery. And the data was included from 1943 to 2022. A total of 31 studies were included for review, and from these, 21 were also included in the meta-analysis. So the total pooled sample size of the systematic review was 48,000 patients, or around 48,000. And for meta-analysis, it was 10,954 patients. The level of evidence ranged from 21 studies were classified as 2B, 3 studies were classified as 3B, and 7 studies as level 4 evidence. So as far as results, conservative treatment was defined as intravenous and/or oral antibiotics. The antibiotic regimen was not specified in most studies, but the most commonly noted antibiotic, if it was discussed, was vancomycin. The range of duration was anywhere from 4 to 12 weeks, and as far as defining early surgery, this was heterogeneous and ranged from immediately after diagnosis in 5 studies to no specified time from admission to diagnosis to surgery. The most common indication from this review they found was presence of or worsening neurologic deficit. That was 19 studies. And then the next most common indication was failure of conservative management within 12 studies. So overall, 16 studies stated that when taking into account both neurologic and clinical outcomes, early surgery yielded better outcomes. Unfortunately, this definition of clinical outcome varied and had significant heterogeneity as well, but overall, no study stated conservative treatment was superior. So as far as mortality, the pooled proportion for early surgery was lower at 8% versus 13% for conservative treated patients. This demonstrated a 39% risk reduction when using early surgery. As far as relapse and failure, the pooled proportion was 15% in early surgery and 21% for those treated conservatively. And this demonstrated a 40% risk reduction for relapse or failure. As far as length of stay, those treated with early surgical management demonstrated a 7.75-day decrease in length of stay compared to conservative treatment. They also did subgroup meta-analysis, so 6 additional subgroups were ran. 2 were on mortality, 2 on relapse and failure, and 2 on length of stay. This was computed using studies that focused solely on patients with spinal epidural abscess, and then a separate meta-analysis on those, excluding those papers that focus solely on SEA. So early surgery was more effective than conservative therapy for those with purely spinal epidural abscess, which is kind of intuitive, but early surgery was even more effective in those without SEA. They had 10.6-day versus 6-day length of stay reduction, 44% reduction in mortality compared to 33%, and 54% reduction in relapse rate compared to 26%. So those without spinal epidural abscess with early surgical intervention did better than those with. Another multivariate analysis demonstrated several positive prognostic factors in those treated surgically that included IV drug abuse or a cervical location of the discitis. Negative prognostic factors were diabetics, thoracic or lumbar location of the discitis, positive blood cultures, presence of epidural abscess, and advanced age. So in conclusion, early surgery had 39% risk reduction in mortality, 40% risk reduction in relapse and failure rate, and a shorter hospital stay by 7.75 days. So all of this combined suggests that early surgical management of spondylodiscitis may be more effective than conservative therapy. Strengths of this analysis were, it is a large pool of patients greater than 10,000. They did use multivariate regression in meta-analysis to exclude and include spinal epidural abscess. Weaknesses overall, although there were some higher level of evidence studies, overall it's level 4 evidence, and there were no randomized control trials. There was heterogeneity in outcome reporting, and there's a moderate risk of bias, especially selection bias, which is kind of inherent to this problem. We often treat the more sicker patients conservatively, and the less, overall comorbid patients were more readily head to the OR. So I think the problem itself has a high selection bias. So key takeaways for me in my practice are that in patients who present with isolated spondylodiscitis without epidural abscess, medical optimization and then operative intervention with stabilization is a viable option during that initial admission rather than reflexively pursuing conservative management.
So that was a really cool paper that you found there, and it was something that in my reading strategy I had missed, must admit. PLOS is a great journal in a lot of ways, but I don't have it on my reading list directly, so I thank you for bringing that up. Can you go back to that nice graph of the multi-risk factors? Dr. Placide, I thought this was a terrific graph because this visualizes statistically and itemized in an itemized fashion the famous comorbidity kind of impact on the disease state of patients. How does this paper help you? Does this kind of change how we think about the interplay of surgery and infectious disease management with antibiotics?
Right. So it does add a few factors to look at, but typically we're pretty aggressive with infections, and we will use the scoring systems such as site score and the POLA, and we will also use other factors such as diabetic, their dialysis patient, their infection is a methicillin resistant staph. You know, we know those things tend not to heal well with non-operative care. So this just adds a few more factors we can look at.
Yeah, I thought it was a very comprehensive look and overview of the literature and collation. And again, all of us need to still try to work better at standardizing our reporting outcomes. And it's so hard. And some of the target populations are really difficult to follow up. But again, the visual impact of this, just not only for infectious diseases, but other reporting such as oncologic diseases, was really nicely put together here. I thought this is a very evocative graph. We'll close. Thank you, Dr. Minisali. That was a really nice paper. And we'll close out with Dr. Julius Gerstmeier. He's our soon departing research fellow from Bochum, Germany. And he is actually a partner of Dr. Jonathan Plumer, who published the site score and worked very hard on that together with his home center in Bochum, Germany. Bochum, just so you know, is the oldest trauma center in the world and was the second hospital in the world that had something called Röntgen machine, an X-ray machine in the world. So this is actually the second hospital in the world. So they have a very long and storied track record. It's a major trauma center in Germany and in Central Europe to the present date. Julius, thanks for your work, and thanks for talking about this site score to try to help us make up our mind what we're dealing with.
Well, thank you for this very kind introduction, Dr. Chapman. Good morning, everybody. I have the courtesy to speak about the site score today, a great project with follow-up projects of a colleague and a former fellow of this institute as well, Jonathan Plumer. He's now attending at the University Hospital Bergmannsheil and can't give this talk at the moment due to conflicts with the OR schedule, but I'm happy to do this for him. So in this talk, I will not only present a single paper, but the whole idea behind the concepts and the follow-up projects that was published. This is a site score to all of those who are not aware of this. I put the QR code in so you can have a direct linkage to the paper. As I said, it's not only one paper, but we have a follow-up paper that investigates a couple of scores and the validity behind this. So what was the reasoning behind doing any of these projects, and is there a need for others? So the goal was to build a structured and comprehensive checklist, like a guiding tool in a treatment of these de novo spinal infections, so spinal infections that are not related to a postoperative status or instrumentation. And we can ask the question, is there a need for yet another system, for another classification system? But when we think about how we make decisions in surgery, more general approach, it seems to be sometimes more individual or anecdotally, especially in cases of de novo spinal infections. So in other words, you could sometimes say that I just know it when I see it, what an infection is, in the famous words of Potter Stewart. When we analyzed the current nature or the current classifications published, we see a variety of different classifications, but when looking at it, taking a deeper look into those, we see that they are lacking important factors. So some of them miss neurological symptoms or comorbidities as a variable. They lack variability, and some of them only represent a single expert opinion. So the approach of the first study was to perform a literature review. Key factors were then reviewed by an expert panel using a Delphi method. Then we had the first side score, and then it was presented to an expert panel again with changes made and then a validation. So if we delve into the side score, this is it. We have 5 components that address different variables, different symptoms, different findings. So we first have neurology, then we go into location, radiological findings, pain, and then other comorbidities as well. So let's delve into it in more detail. I will skip neurology because this is very clear. Acute neurological deficit or paraplegia in infection is a direct indication for surgery. So if you look into location, this is adapted from the SIN score that we all know and use in oncologic patients to define regions. Furthermore, we included a checklist tool for radiological findings, both CT and MRIs, judging for impingement of central neurological elements, angulation, erosion, edemas, as well as the integrity of the posterolateral elements. The attached references should be given an idea behind the evidence of the score. It is noted that the stability there's no evidence out there yet for clear instability of the spinal column in infection papers. So the instability can be assessed by various amount of variables, including the location, radiological findings, and pain of the patient. And lastly, we included several comorbidities that we know from various other studies, also from this institution, that increase mortality and risks in those patients. For example, we all know the IV drug abuses, diabetes, and so on. So when tested in the validation of the score with 30 patients, we had nearly perfect intra-class correlations and higher intra-observer reliability, as well as a high sensitivity and specific values of the side score, which then led into the second paper that I discussed, where we did a validation against different scores on a larger cohort, because you might say 30 patients, that's really not enough to validate a score. In this paper, we reviewed 123 patients, and an expert panel of 3 surgeons did scoring for all of these 3, with every expert given an individual treatment a decision. And we also had a subdivided patient cohort with those having a discitis and those with discitis and an epidural abscess. So when now delving more into the data, we see that the side score overall has a high sensitivity and specificity for a broad cohort of the de novo infections, as we already saw in smaller cohort study. And the sensitivity and specificity for patients with epidural abscess was significantly higher compared to those of the other scores, which shows that a pure radiological judgment based on instability seems not to be comprehensive enough on making a decision. Furthermore, the side score showed a significantly higher agreement for the definitive treatment in our expert panel compared to a decision by a single physician. So I would like to end this talk with thanking Jonathan for such a great work and the support from this institution. And this is not something I would exclude. So this is Jonathan during his time here in Seattle, and some images of our home institute, the Bergmannshalle in Bochum.
Well, thank you very much for this overview. And again, this is just the beginning of something where there was an international collaboration between a German institution and a U.S. Location that has a lot of spondylodiscitis patients, and we appreciate the help from your institution and your eminent colleagues to try to help us formalize our thoughts a little bit more. Dr. Placide, it was a real treat to have you here today. So we have to be leery of scoring systems. How does this help you? Does this help you, first of all, as this and Dr. Reznicek, as you see your patients, to kind of structure thoughts? Does it help your trainees and your colleagues to kind of develop a lingua franca, common language to exchange severity of patients?
So personally, I think it helps tremendously. It's not the sole decision maker. You put everything else into the decision-making process. There's a lot of other factors, but it's a significant, and we do teach the residents and fellows this. Unfortunately, some of the colleagues in our area are over-conservative with spinal infections to a detriment often of the patient. So it has not spread in our local area as something that I would share with other surgical colleagues. I certainly have this discussion with Dr. Reznicek. So within the infectious disease community, yes.
I think what you've created is a model center. I don't know how to express that scientifically in terms of having this very close interaction of a traditional medicine specialty and a surgical specialty. How can one popularize that more? How can one make this kind of eminent? Is there some evidence that you can think of to kind of show that this is a superior approach and actually helps everybody, first and foremost our patients, but also the healthcare systems?
So that's a great question because it's relatively new concept that we have at VCU. And Dr. Reznicek and I have been talking about that exact point. How can this be, what is the next step? How can we take this forward? Because we're biased, obviously, but we think it's a really good approach for patients and overall outcomes. But that's a good question. How do we prove that? And yeah.
I mean, how has this score helped you? Is this something that you routinely put into your patients now? We have it obviously in EPIC as a system.
Yeah, I mean, obviously we're biased having, spent so much time invested in this, but absolutely. And I think a lot of the studies that we looked at today show that kind of the traditional ways of treating infection may be a little bit too conservative, as we just mentioned, and I totally agree. I think that, a little bit more aggressive treatment of these earlier on, we can help patients get out of the hospital, get back to life a little bit more quickly, and in some cases decrease mortality. I think those are all really important things that the studies have shown well today, and hopefully that will kind of trickle out into the spine community and help us treat our patients more effectively.
Yeah, we would obviously love to continue our collaboration with you. Dr. Placide, it was a real treat. Please extend our best wishes, Dr. Reznicek, and our
thank you.
Your work and your colleagues' work, and thank you to our audience today. I want to flash out a picture of a shout out for Corey and Ben. Can you pull up that picture? So Corey and Ben, they came in early today on short notice, and look at their matching outfits, Corey and Ben.
Nice.
They are the true stars. They made it happen at 6 a.m. Pacific time. Thank you all. Go through your days well, and thank you for putting up with us as a replacement act for our Rothman colleagues who will make up for it. And Dr. Placide, great to have you across the country. Say hi to Dr. Cates also if you run across him.
Of course I will.
With admiration. Thank you.
Thank you.